Hi, today we're going to talk about polypharmacy in older people. This is one of 3 short talks on the TEMA website looking at common conditions in older emergency department patients. For those of you who are interested, the other 2 talks are on sepsis in older people and falls in older people. Let's start with a case. So this is an 89-year-old female patient brought to the emergency department by her granddaughter with whom she lives. She's become more restless and aggressive over the past 3 days, and on questioning she tells you that she was brought here because they are trying to get rid of her. However, when you talk to her you realize that she doesn't know where she is and is not clear about what day it is either. So what are your thoughts about this patient? You can stop the video here and I just want you to think about a couple of things. The first thing is just try to recall what might cause delirium in an older patient like this lady. There is a lecture on delirium in older people in this section on psychiatric emergencies. After you finish this, you may want to have a look at that. More specifically for today's talk, I want you to think about how drugs and drug interactions might have affected this patient's mental status and may have either produced or contributed to her acute confusional state. At the end of this lecture, you will be able to describe polypharmacy in older people, and particularly in relation to its epidemiology, pathophysiology, clinical presentation, the impact on outcomes, and its identification and management. So again, just pause the video and see if you can think about what might cause delirium in an older person. Well, one cause is drugs and polypharmacy, and that's what we're going to elaborate on in this talk. But remember 2 things. One is that there are other causes of delirium in older people, and that often in an older person who has delirium, there may be multiple causes contributing to the acute confusional state, such as infection, metabolic conditions, diabetes, thyroid problems, renal problems, liver problems, depression and alcohol abuse, and intracranial pathology. But as we said, today we're going to focus on polypharmacy. So what is polypharmacy? Well, actually the definition is not completely agreed, and the number of drugs that constitute polypharmacy varies from one research study to another. However, in a broadly accepted definition that is emerging is that polypharmacy is defined by the use of 5 or more medications simultaneously, remembering that these may include over-the-counter preparations and herbal formulations. Now, if you think about our older patients, you can see why this can be a real problem, and especially in our setting, our older patients may already be on multiple prescribed medications from their physician, and often supplement this with either over-the-counter medication or, in our setting, herbal formulations as well. The prevalence is high. So we have a study here by Slabau in Italy from 2012, which showed that 39.4% of emergency department attenders were diagnosed with polypharmacy. We also have local data from Darren Dukiram, and in his 2014 study, he found that 44.7%, or nearly half of all emergency department attenders, were on 5 or more medications. Similarly, the rate of as you can expect, when we're taking multiple medications, the risk of drug interactions is much higher. And we can see that one study from Saudi Arabia found that 83% of the drug-drug interactions seen in patients with multiple medications could be avoided. And Andreazzi in Brazil showed that 1 in 3 of all attenders had potential drug-drug interactions. There's an increased risk of falls in patients on multiple medications, and this was shown locally by Yogi in 2017. There's also increased risk of hospitalization, as demonstrated by Reuter in 2012. So, polypharmacy and drug-drug interactions are a serious condition seen in older people with potential serious outcomes. What about the pathophysiology of polypharmacy? What is so bad about taking multiple medications? Again, you might want to pause the video here and just try to come up with your own ideas about why polypharmacy might cause problems. So, the kinetics of drug absorption, distribution, metabolism, and elimination may be affected by other drugs. And we know the typical examples. We think about things like warfarin and many drugs that interact with warfarin, such as cimetidine, even grapefruit juice. We can also think about distribution in terms of aspirin, which is highly protein bound, and many other protein bound drugs. For example, thyroxine, one displaces the other and can inadvertently increase the toxicity or side effects of the drug by releasing more free drug. Similarly, drugs that affect the P45 system in the liver will increase or decrease the metabolism of drugs, and drugs that affect renal filtration may affect the elimination of drugs that are got rid of in the kidney. So, for example, if you're on a sulfonylurea and then you start taking a non-steroidal, and the non-steroidal reduces glomerular filtration, that might increase the effect of the sulfonylurea and actually lead to hypoglycemia. So adverse effects from polypharmacy may be summative or they may be idiosyncratic. So they may be predictable that you're taking two drugs, and as you increase the dosage of one, it affects the other, or it may be just an absolute and idiosyncratic reaction, unexpected, because of the combination of drugs you're taking. Remember that many drugs affect the pharmacodynamics as well, and that may be additive. So, for example, if you are on a sedative which causes respiratory depression, and then you're given an antipsychotic that also causes respiratory depression, the adverse effects can build up. Similarly, if you are on a calcium blocker that blocks the AV node, and then you're given a beta blocker, that can actually cause complete heart block because of the summative effect. Also, drugs that cause psychiatric side effects may be summative. So if you are on an antipsychotic and then you start an antiemetic, the combined anticholinergic effects can lead to acute confusion. How do people present with polypharmacy? Well, we saw delirium. They may have cardiovascular effects. Patients on an antihypertensive then put on another drug that causes vasodilation may present with faints and blackouts due to postural hypotension. The disease control can go out. So you have somebody who is diabetic on a sulfonylurea or insulin, and then they started on steroids because they were wheezing, and of course the steroids will adversely affect the diabetes and the disease control. Sometimes it's the opposite. Sometimes if, for example, you are on warfarin and then you start taking a drug like cimetidine, which inhibits the metabolism of warfarin, your INR might increase and your tendency to bleed might increase. And finally, actually, patients who have multiple medications that are causing adverse effects may present with repeated falls, and this could be for many reasons: postural hypotension, muscle weakness, confusion. What about drug interactions? So Darren Dukiram's study showed that some of the common drugs that are implicated in potential drug-drug interactions in Trinidad include aspirin, antihypertensives, particularly ACE inhibitors, oral hypoglycemics, and clopidogrel. In other studies have also shown the potential for drug-drug interactions with warfarin, psychotropic drugs, anticholinergic drugs, non-steroidals, and opioids as well. So here are some of the actual interactions that we see a lot of. Analgesics and sedatives given together, particularly opioid analgesics, and therefore the sedative effect is worsened. Warfarin plus any P450 modifiers either drugs that increase the efficacy of the P450 system or decrease it. Non-steroidals and steroids, both of which are adversely on the upper GI epithelium, and aspirin and any protein-bound drugs, like the example we gave before, which is thyroxine. And then we actually give drugs that counteract each other. So we might give a beta blocker for hypertension, and then the patient comes in wheezing, and you give a beta stimulant. There is no logic behind that. Also, if we have a non-steroidal which affects the GI system and an H2 antagonist to reduce acid secretion in the stomach, the two drugs are working against each other. How do we deal with and really prevent drug-drug interactions and polypharmacy? Well, if you see somebody with an odd presentation, ask yourself, can this be drug related? Even if the symptoms are not primarily caused by the drug, ask yourself, are the drugs making the symptoms worse? But before you modify somebody's drug regime or stop it, ask yourself and think about what happens if you stop the drug. So what we're going to do is identify the adverse drug effect. So anything somebody comes in with, an older person, think, is this an adverse drug effect? If it is, are the drugs needed? Even if they are, can you stop them safely or replace them safely? If you take this approach to drug reconciliation, you can identify lots of drug interactions and safely modify the patient's regime to give them a better overall outcome. Bear in mind, our job is really to identify the adverse drug reactions, and also the other steps will be taken care of by the patient's primary care physician, but the primary care physician will not know that we have a problem unless you speak to them, send a letter, advise them that maybe some of these drugs should be stopped or modified. If you have any questions, you can post these on the website or on our WhatsApp group. So in summary, polypharmacy is very common in older people, and every time we see an older person present with an acute problem, we need to ask ourselves if this can be drug related, and if it can, is there some way we can modify the patient's drug regime to cater for this. These are my references. You may want to look up some of these and read them yourselves.